Welcome to this third and final part of week 1 of our course. And during this week, we're going to look at how to decide whether interventions are cost-effective relative to other interventions. And in the last part, just to recap, we looked at the definition of economic evaluation, which is the comparison of one or more interventions. And in the first part, we looked at the different kinds of interventions. And this comparison is in terms of both costs and outcomes. And these outcomes are health outcomes. And we looked at how the gold standard health outcomes are DALYs and QALYs. And by now, you should know what these two terms mean. We start out by looking at opportunity cost and technical efficiency, as well as allocative efficiency. When you use resources to meet some needs, the benefit which would have been obtained by the next best use of resources is what is referred to as the opportunity cost. So for example, the opportunity cost of your time right now listening to this video is what you'd otherwise be doing. Maybe you would be out having dinner with a friend, or you would be attending another class, or you would be doing something fun with your child. That's essentially the opportunity cost. Now, efficiency arises when benefits are maximized and opportunity cost is minimized. And if an intervention is less costly and at least as effective, then you have what we call technical efficiency. If you equalize effectiveness and you reduce cost, then that intervention is technically efficient. Now, if an intervention is more costly and more effective, you need a judgment. And the question is the extra cost worth the extra benefit? And this is a question of what we call allocative efficiency. Let's look at this effectiveness cost matrix, which you can use to compare a new intervention. Maybe it was B and the standard of care, which we can call A. And above here, you have declining effectiveness. So in one, you have intervention B is more effective than intervention A. Here you have intervention B is as effective as intervention A, and here you have intervention B is less effective than intervention A. And here you have increasing cost. Here it is the new intervention is less costly of equivalent cost, and here it is more costly. So you have three situations in which the intervention should be adopted, and that is when the new intervention increases effectiveness and reduces cost, increases effectiveness and does not affect cost, or does not affect effectiveness but reduces cost. So you have this green area here. And then you have the bad area where you shouldn't adopt the new intervention, and that is when you have reduced effectiveness and the same cost, reduced effectiveness and increasing cost, and no evidence of increasing effectiveness. So the effectiveness is the same, but you have increasing cost. So this is the bad area, and you don't essentially adopt the new intervention. You have an indifferent region in which the new intervention is as effective and costs the same. So here it's indifferent. You're not interested in one or the other. Now you have the two boxes where judgment is required. And in this box, you have an intervention that reduces effectiveness, but it also reduces cost. So you need to make a decision. And here you have an intervention that increases effectiveness, but also increases cost. So you also need to make a decision. And to make that decision, you need added evidence. Building on the last slide, we're going to simplify it a little bit and make just 4 boxes in what we call the cost effectiveness plane, and we'll keep coming back to this plane because it's very important. Here in the center you have the comparator, the intervention being compared. In this case we have intervention A, which is the base case or standard of care, and we're comparing to intervention B, and we have 4 quadrants, and if you use the compass you can call them the northeast, the southeast, you have the southwest, and you have the northwest, and you can use them to describe whether intervention B should be implemented relative to intervention A. In the northwest quadrant, you have an intervention that increases cost and lowers effectiveness. So intervention B relative to A here increases cost and reduces effectiveness. It's a bad intervention. And we say that B is dominated because it increases cost and lowers effectiveness. So the decision rule is a no-brainer. You don't adopt intervention B. In the southeast quadrant, here you have an intervention that increases effectiveness and also lowers cost. It's a fantastic intervention. This is something you should do, and it's a dominant intervention. So B is said to be dominant, and you will see in papers people say dominant or dominated. Now we have these two quadrants, the northeast and you have the southwest, and in these quadrants a decision is required. And in the northeast quadrant, the decision that is required is if the increase in cost is worth it. Essentially, if you increase cost, how much benefit do you buy? And in this one, it's if the savings are worth the reduction in effectiveness. Now, to do that, we measure what we call the incremental cost effectiveness ratio in this quadrant in the northeast, and here we measure the decremental cost effectiveness ratio, and that's simply the gradient of a line going from the base case into the quadrant, and the ISA is just the change in cost divided by the change in effectiveness. So change in cost divided by change in effectiveness. And we will build on the idea of the ISA in the next slide. So in the northeast quadrant, you have what we called the incremental cost effectiveness ratio, or the ISA. Let me write it down just to emphasize it, because it's an important metric in this field. So the ISA, the intervention is more costly and more effective, essentially. So innovative technologies tend to be in this quadrant, in the northeast quadrant, because there's a premium on innovation. A drug company isn't going to make a new drug and sell it at a low price, essentially, or sell it at a low price relative to the standard of care, because presumably their new intervention is actually providing some benefit. So the ISA is the mean cost of intervention B minus the mean cost of intervention A over the mean cost of the mean outcome of intervention B and the mean outcome of intervention A. And these outcomes will look at how they define the method of economic evaluation. But the important thing is that these outcomes must be in the same units. On the cost side, you just have currency. I put here Uganda shillings. We spoke about Malawi kwachas. You can have yens, euros, dollars, whatever. And like I said, for the intervention, for the denominator of the ratio, it has to be in the same units. Here are some examples of ISAs. This is the cost effectiveness plane. This is northeast. You have here southeast. You have here southwest. And you have here the northwest. And as you can see, they are all in the northeast quadrant. So, for example, we have home dialysis compared to transplantation for renal failure, and the ISA was 79,000 US dollars per quality adjusted life year. And you have intensive care for patients who are seriously ill with multiple trauma, it's almost $500,000 per life year gained. And you have cervical cancer screening every 5 years for women who are over 35 years and have more than 3 children, and that ISA is lower. So as you go down like this, the ISA gets smaller. So you want an intervention with a smaller ISA because you're using less money to buy more health, essentially. And we'll look at how to decide whether an intervention is cost effective given a certain ISA. So there are 3 approaches to determining if an ISA in costs per DALY averted or cost per QALY saved represents value for money or is cost effective. And those 3 methods are thresholds, benchmarks, and league tables. And we'll speak about each of them one by one. Now you'll notice that these approaches are benchmarked on ISAs calculated in cost per DALY and cost per QALY, and we said that dollars per QALY saved or dollars per DALY averted are the gold standard measures. We'll see next week that you can have studies that don't use QALYs and DALYs, but these decision rules for deciding whether interventions are cost effective are premised upon doing studies with estimates measured in QALYs or DALYs. So let's look first at thresholds, and the most common threshold used is GDP. It's GDP, the GDP-based threshold, and it says that an intervention is highly cost effective if the ISA is less than the GDP per capita of the country in real terms. And it's cost effective if the ISA is between GDP and 3 times GDP. So below GDP, let's say you have a country like Uganda whose GDP per capita happens to be about $500. An intervention that's less than $500 per quality adjusted life year gained or disability adjusted life year averted is highly cost effective. And an intervention that's between $500 and $1,500 per QALY gained or DALY averted, this is 1,500, would be considered cost effective. Now the problem with this threshold is that it obscures important comparisons, because essentially you can have a huge range of ISAs, and given budget constraints, you won't be able to decide what's the best use of resources. So you can have, an intervention with $490 per QALY and one with $2 per QALY, and you will say that all these are cost effective and that the government should essentially pay for these interventions. The other problem is that thresholds are so easily attained in studies, and this method is based on untested assumptions with no empiric data. Like I said, it doesn't take into account affordability. So it says pay for this intervention and pay for this intervention without looking at a budget constraint. Now, high-income country thresholds vary but tend to be much higher. So in the UK, you'll find that the National Institute for Clinical Excellence considers interventions that are between 20 and 30,000 pounds per QALY to be cost effective, although there's a new study they've done which suggests that that threshold is more around 13,000 pounds per QALY. In the US, anything between $50,000 and $200,000 per QALY is considered cost effective. So a much higher threshold than for a country like Uganda, say. So we said that an ISA essentially is the calculation where you have the cost of the new intervention minus the cost of the old intervention divided by the effectiveness of the new intervention minus the effectiveness of the old intervention. So let's say that this calculation gave you $10,000 per quality adjusted life year. So the second way to decide whether this is cost effective is to use what we call a benchmark intervention. And what a benchmark means is that the ISA of an intervention that has already been adopted by society in that country or that jurisdiction. A good example is dialysis, renal dialysis for patients with end-stage renal disease in the United States, and it's used to be about $50,000 per quality. So what it suggests is that this is the willingness to pay in this society for healthcare, for quality adjusted life year essentially. So anything that is below this threshold is considered to be cost effective, or anything that is below this benchmark is considered to be cost effective. So in this case up here, this 10,000, this intervention B would be considered cost effective based on this benchmark. And many analysts believe that this approach exhibits better local relevance. It has some limitations. One is that you can have a benchmark which is a high or low outlier, and it also doesn't consider budget impact, doesn't consider affordability, and in later weeks we'll talk about budget impact analysis. And there might be available options that have a better ISA than either the benchmark or the intervention and the evaluation, and so the benchmark doesn't provide a good way of deciding whether an intervention is cost effective or not. Then the final way is called a league table, and a league table is essentially a list of ISAs ordered by increasing cost per quality. So let's say you had intervention A, B, C, and D. Intervention A has a quality of $1 per quality, an ISA, sorry. Intervention C has $5 per quality as an ISA. Intervention B has 50 per quality, and intervention D has maybe 500 or 800 per quality. Forgive my handwriting. So if you list them, then it means that you begin by essentially adopting intervention A. If you still have a budget, you go to intervention C. If your budget holds, you go to intervention B. And if your budget still holds, then you go to intervention D and implement it until your budget has been exhausted. Now it assumes that health outcomes are maximized if you start with interventions with a small ISA, which is the top of the league table. Essentially, this would be the league table. Now, there are different kinds of league tables, and some are big and some are small. There's a huge one called the Tufts Registry, and you can look, if you Google Tufts, you'll see a bunch of studies with tons of ISAs. The WHO also has some league tables. One of the papers assigned this week, you'll find some examples of that. The limitation is that ISAs may not be available for many relevant options in certain settings, so you don't have a complete league table and you don't have complete information. The advantage is that they explicitly consider the budget, so they consider affordability, and they need not be comprehensive to support improved resource allocation. They can indicate the benefit of cancelling some programs and funding new ones. So in summary, we have those three approaches. The first one is GDP based. The second one is based on a benchmark. And the third decision rule is a league table. Here's an example of a league table in this paper by Massey et al. in the bulletin of the World Health Organization, and it's on the cost effectiveness of malaria interventions in the WHO Africa region called Africa D. And you see it has 4 interventions. One is this MAL 27, which is case management with ACTs and 80% coverage. The second one is 95% coverage of the same thing. The third one is adding IPTP, which is intermittent preventive therapy for pregnant women, and mosquito nets, ITNs. And again, here you have the same intervention, but you now add indoor residual spraying. So you can see that in terms of dollars per daily averted, this first one had $9 per daily averted, went up to 16 for the second one, 59 for the third one, and 96 for the fourth one. And this is in international dollars. And in week 3, we'll look at the concept of international dollars and how they compare to regular dollars. But suffice it to say that if you had a certain budget, you would essentially do this intervention first, and then if you still have money, do this one. If you still have money, do this one, and finally go to this one. So this is an example of a league table. Let's look at the southwest quadrant of the cost effectiveness plane. You have increasing cost, reducing cost, increasing effectiveness, reducing effectiveness. Here is an intervention that you do not want. Here is an intervention that you definitely want. It increases effectiveness and reduces cost. Here you have to calculate an ISA, which is that, change in cost over change in effectiveness. And in this quadrant, you have to calculate a DISA, which is also a change in cost over the change in effectiveness. And the theory is that you could reduce effectiveness marginally and essentially generate substantial savings, and that these savings, this money, can be put to higher value alternative healthcare interventions. And a higher DISA is better. And we saw that a lower ISA is good, but a higher DISA is also good. And what that means is that for a small reduction in effectiveness, you are generating a huge amount of savings. Now, in rich countries, almost all interventions are in the northeast quadrant. It's very rare that you find that a health insurance company or a rich country is paying for an intervention that reduces effectiveness in any way. But in poor countries, I can see some situations where you might want to take, as a policymaker, an intervention that reduces effectiveness marginally, but generates substantial amounts of savings. And here are some examples in the literature, including a study by me and my colleagues that had a DISA of $13,000 for a favorable immune response, which was a reduction in CD4 count below 500 in a patient with HIV for HIV follow-up. And we'll look at this study in detail. But for a reduction in this favorable immune response, there was a savings of nearly $1,400. Another example is watchful waiting for inguinal hernia, which saved $194,000 per QALY. And there was this PCI for multi-vessel coronary artery disease, and in this study by Weintraub, the DISA was essentially $3.2 million. So this would be considered to be a valuable intervention, essentially, despite the marginal reduction in effectiveness. So let's move on and talk about the importance of incremental analysis. And we'll use this example of the 6th Stuhl-Guyac test in a classic paper by Duncan Neuhauser, and it was published quite a while now ago in 1975. And in the mid-1970s, when colon cancer was suspected, they did stool tests, and each stool sample was tested 6 times. So test 1, essentially what happened was someone would test one part of the sample, and if it was positive, then you would move on to additional tests. If it was negative, you would do a second one. If the second one was positive, you would move on to additional tests, up to the 6th one. So the question was this cost effective to do this sequential stool testing? So here are the results for 100,000 individuals screened for colon cancer in this paper by Duncan Newhouser. Essentially, you have in this column the number of tests. So you have 1 test, 2 tests, 3 tests, and so on. And for 100,000 population, here you have the number of cases detected. So in the first test, you detected 65 cases, second one 71.4, third one 71.9, fourth 71.9 again, fifth one 71.9 again, and sixth 71.9. And the costs of detecting those, you have those different numbers in this column. And the calculation is just simply the cost divided by the number of cases, and the result here is the average cost effectiveness ratio. This is the average cost effectiveness ratio. And as you can see, you have, $1,100, $1,500, $1,800, $2,000, up on to 2,451. So this was an average analysis. Now let's look at the incremental analysis on the next slide to try and make the point about the importance of incremental analysis. Now let's say you did an incremental analysis. Remember that we still have a population of 100,000 individuals screened. On the first one, you detect the same 65 people, and the costs are $75,000. And let's leave the others blank because we have added a column for incremental cases and incremental costs, and we have our ISA, which is the change in cost divided by the change in effectiveness. And here the effectiveness is number of cases detected. So if you move to the second test, the incremental, so you have now 71.44 cases detected. The incremental number of cases detected is this minus this, which would be 6.4 cases detected. But how much money would you have to pay for that? You would have to pay this minus this, which would be $30,000. So to detect the second case, you need to pay $4,700 essentially per case detected. So it's $4,700 to detect the second case. Now let's do that for the third case. Now you only get an additional half a case, but you have to pay $22,000. So per case detected, you're nearly $50,000. Now if you go to the fourth, you get just a small fraction of a case detected. Now remember that this is a fraction, a very, very small number. If you increased this maybe to 100 million, you would have real numbers in that estimate, but it's a very, very small increase. And you are now paying $17,000 to get that small benefit. So you're now at $500,000 per case detected. If you go to the fifth, you go to $5 million per case detected. And to the sixth, you go to nearly $44 million per case detected. So it's very clear that if you do an incremental analysis, going even to the third test is not worth the money. But if you look at the previous slide and measure an average cost effectiveness ratio, you get a fallacious result because it looks like you're actually gaining something. But an incremental analysis is important to be able to see the added benefit that you get for the added cost. And this is the importance of doing an incremental analysis when you do an economic evaluation. So we now come to the end of part 3 of week 1, which is also the end of the recordings for week 1. And we can summarize by saying we first defined global health and health systems, and we looked at the interventions that we can assess using economic evaluations. We talked about the definition of economic evaluation, which is the comparative analysis of one or more interventions, and you have both costs and outcomes being assessed. We also talked about the rationale of economic evaluations and the importance of putting formal numbers on things and not making decisions the way we normally make them in our daily lives. And then we talked about the cost effectiveness plane. If you have cost there and effectiveness there. We talked about the ISA, change in cost over change in effectiveness, and we finished talking about the importance of incremental analysis instead of average analysis. So in the videos for week 2, we are going to talk about the methods of economic evaluation. So with that, I would like to thank you very much, and I'll see you in the videos for week 2. Thank you very much.